Hey, Dr. John Swetech here at Swetech Medical Center. Wanted to talk about cholesterol today. We deal with this with evaluating and treating lipids all the time, and just want to give you some background. So, society's got it a little backwards, and we do kind of look at cholesterol in the wrong way. So, when you go in for a physical or a checkup, they check your cholesterol, and if it's high, they try to get it under control with lifestyle and things like that, and if not, then they try medications. So it's kind of an indirect measure of the inflammation in your blood vessels. And let's kind of look through the history, and we'll talk about where this came from and how to better approach the situation. So way back in the day, we still have this disease around now, but it started with these people that have familial hypercholesterolemia. Their cholesterols in their families would run 300 and even higher. These people had a lot of heart attacks and strokes. They developed statin medications, and they had less heart attacks and strokes. These statin medications were found to lower their cholesterol numbers. So some brilliant scientists decided to give this to the general population. And they gave it to many people, and they had less heart attacks and strokes. I keep saying heart attacks and strokes because that's the main thing we treat these lipids for. So we noticed that the cholesterol number also came down in these people. However, as time went on, we realized this wasn't necessarily a direct causation link. It was more of a correlation. Why do we think that? We've tried other medications that also lower cholesterols. These non-statin medications don't necessarily seem to actually make a difference in the heart attack and stroke risk. There's some new ones out that are injectables, and they also brought the cholesterol level down. They are very useful in people with the familial hypercholesterolemia, but not really the general population. There's a newer study out that kind of says otherwise, but it's time will tell. It's a very complicated question. But the bottom line is there are ways to measure the inflammation. You can do CRP levels. There's all kinds of fancy labs with all kinds of other tests. But the cardiologists have pretty much caught on to this too. They do recommend a one-time cholesterol check on their current guidelines to kind of use as a starting point, but they base their statin dosing off of a lot of risk factors, like whether the person is overweight, whether they are a smoker, whether they have diabetes, whether they have heart attacks and strokes that run in the family. So they kind of are telling us that, yeah, this level is a little bit of a useful monitor, but there's something else going on, and we're thinking inflammation. So it's kind of an interesting thing. They did some cadaver studies, and they also found out that the cholesterol number was not necessarily linked to the amount of calcium in the coronary arteries. Those are the arteries around the heart. Hopefully this wasn't a lot at once, but the fact is we see this number and we try to bring it down, and usually it is a good idea, but it doesn't tell us the whole picture. So if you're interested in talking about it, get in. Hopefully that gives you a little bit better thing. By all means, always discuss these things with a physician. Unless someone's running really high, I usually try to get it under control with lifestyle modifications. And it does get a little bit more complicated because the endocrinologist made some separate recommendations, and sometimes they're saying everyone with diabetes should be on a statin. But I did wanted to share that this number that we get doesn't tell the whole picture. So get in, let's talk about it, or talk about it with your physician. Have a good one. Thanks. Bye.